Picture the scenario. It's midnight.
Never a good time.
Right. You are standing in the casualty ward, or maybe you've just been scrubbed into the operating theater.
And you're exhausted.
Completely exhausted. The fluorescent lights are giving off that low, relentless buzz.
Yeah.
The monitors are rhythmically beeping in the background. And the tension in the room is practically a physical weight on your shoulders.
It's palpable.
It really is. And in front of you is a patient. He's a 45-year-old manual laborer.
Okay.
He presents with a 2-year history of a groin swelling.
Which is incredibly common, you know.
Extremely common. For 2 entire years, he's just ignored it.
He's worked through the discomfort.
Exactly. Pushed the bulge back in when it bothered him on the job and just carried on.
Right.
But tonight, the entire clinical picture changed.
Something failed.
Tonight, the swelling didn't reduce. He has arrived on your watch with active vomiting.
Oh, wow.
Yeah, severe, unrelenting abdominal distension and a look of absolute panic.
Because he knows something is seriously wrong now.
He knows it. And your senior surgeon turns to you, locks eyes over their mask, and demands to know right then and there.
Is this direct or indirect?
Right. Is it reducible? And what is the absolute next step we are taking?
It's the ultimate high-stakes clinical crucible.
It is.
And it is a scene that plays out in surgical wards around the globe every single night.
So if you are listening to this, and you can honestly say that in that specific room, under that specific pressure, you would hesitate.
Even for a fraction of a second.
Yeah, even for a second, to answer your senior, then this deep dive is custom built for you.
Absolutely.
We have a brilliant stack of source material to get through today. A comprehensive surgical masterclass dedicated entirely to the inguinal hernia.
The bread and butter of general surgery.
Right. And our mission today is to take the most common surgical condition you will probably ever encounter in your career.
And paradoxically, one of the most fundamentally misunderstood by those in training.
Yes, and we want to completely rewire how you think about it.
We aren't doing a textbook read-along today.
No, we are deconstructing this from the ground up.
Which is the only viable way to approach this. I mean, we need to establish an anti-memorization stance right out of the gate.
I love that, anti-memorization.
We are not here to help you cram isolated facts for a multiple-choice board exam.
Or to give you a quick mnemonics so you can survive a viva.
Exactly. What we are doing today is cultivating actual surgical thinking.
Which is a completely different skill set.
It really is. The objective is to reconstruct the inguinal canal in your mind in 3 dimensions, from absolute first principles. When you understand the architecture of the human body as a structural dynamic system, you stop functioning like a student desperately recalling flashcards.
And you begin to reason like a master surgeon.
That's the goal.
Let me push back on that traditional learning model for a second, though, because I remember the sheer frustration of it.
Oh, it's maddening.
The way this is usually taught, you just memorize binary associations.
Right.
You commit to memory that an indirect hernia goes through the deep ring.
And a direct hernia pushes through Hesselbach's triangle.
Right. And sure, repeating those phrases gets you a passing grade in your first-year anatomy lab.
Gets you the marks.
But when you step into the actual OT...
When you have a scalpel in your hand.
Yeah, and the tissue is inflamed, bloody, disordered.
Relying on a memorized catchphrase is essentially useless.
Completely useless. You can't navigate tissue planes with a flashcard.
No, you can't.
Yeah.
It fails because you memorized a detached outcome rather than understanding the underlying physical mechanism.
Okay, so how do we fix that?
We need to introduce a major paradigm shift right now. This is the core thesis of our source material, and it anchors every single point we will discuss today.
I'm ready.
A hernia is not simply a bulge.
Okay.
A hernia is fundamentally a failure of containment.
A failure of containment.
Yeah.
Okay, wait, let me try to map this out conceptually.
Go ahead.
Instead of viewing a hernia as an invasive entity or like a discrete pathology that just appears out of nowhere, we need to view the abdominal wall as a structural engineering problem.
Exactly. Like a pressurized vessel.
A pressurized vessel.
That is precisely the framework. The primary physiological job of the abdominal wall musculature and the fascia is to contain internal pressure.
Because there's a lot of pressure in there.
Massive amounts.
Yes.
Every time you valsalva,
Right, coughing.
every time you cough, every time you brace to lift a heavy weight, every time you bear down.
You are generating massive, explosive intra-abdominal pressure.
Yes. And the abdominal wall is the rigid vessel designed to contain and manage that pressure wave.
So when we look at a hernia through the surgeon's lens,
Our job isn't to just point at the bulge and categorize it.
right, our job is to investigate the structural collapse.
Exactly. We must ask 3 highly specific questions.
Which are?
Why did this containment vessel fail?
Okay.
Where anatomically is the precise point of failure?
Right.
And how do we reconstruct the architecture to restore that containment permanently?
So, for you listening, whether you are deep in your USMLE prep studying for the MRCS, or you're just looking to refine your anatomical mastery,
Adopting this specific lens changes everything.
it really does. Viewing the human body as an architectural structure that must constantly negotiate and manage physical pressure makes the anatomy suddenly logical.
Everything clicks.
Every fascial layer, every ligament, every neurovascular bundle we are about to dissect flows entirely from this single concept of containment.
If we accept that premise, then we need to actually build the vessel.
Let's build it.
We need to take a 3-dimensional architectural tour of the lower abdomen and the groin.
To understand where the vulnerabilities lie.
Exactly.
All right, let's construct this. If we visualize the anterior abdominal wall, our source material uses a really effective structural analogy.
The sandwich analogy.
Yes. It describes the wall as a 3-layered sandwich.
Right.
On the outermost layer, you have the external oblique.
Deep to that, in the middle, is the internal oblique.
And the innermost muscular layer is the transversus abdominis.
3 distinct muscular sheets stacked together.
But how do those flat sheets translate into the complex anatomy of the groin? I mean, they don't just hit the pelvis and stop.
They certainly do not, and that is where the 2-dimensional textbook illustrations do an incredible disservice to surgical trainees.
They really do. It looks so flat on the page.
Right. But in reality, these 3 layers transform as they descend inferiorly toward the groin.
Oh, so.
They transition from muscular bellies into aponeurotic sheets.
Like tough, fibrous tissue.
Exactly.
Yeah.
And as they do, they fold, weave, and separate to create a highly specific oblique passageway.
The inguinal canal.
Yes, this is the inguinal canal. It is roughly a 4-centimeter tunnel.
Built entirely out of the transitioning fibers of that abdominal sandwich.
You've got it.
A 4-centimeter tunnel. Okay. I want to physically construct the walls of this tunnel in 3D right now.
Let's do it.
If I'm standing inside this 4-centimeter canal, looking forward toward the skin,
Toward the outside world.
yeah, what constitutes the front door? The anterior wall.
The anterior wall, the structure sitting between the canal and the subcutaneous tissue of the skin,
Right.
is formed almost entirely by the aponeurosis of the external oblique.
That outermost layer of the sandwich.
Exactly. And this aponeurosis is an incredibly tough, fibrous, unyielding sheet.
So it's a strong door.
It provides a highly fortified front barrier. Furthermore, on the lateral aspect, toward the outside of the body,
Yeah.
this anterior wall is reinforced by the descending muscular fibers of the internal oblique.
So your front door is robust.
It is structurally very sound.
But if the front door is that well fortified, the pressure has to find a weaker escape route.
Water always signs the cracks.
Exactly. Let's look at the posterior wall, the back of the tunnel.
This is cruel.
Our source material slows down significantly here, and I want to make sure I'm visualizing this correctly. What exactly is making up the floor and the back wall behind the canal?
This is the critical point of failure in our entire structural engineering model.
Okay, pay close attention to this.
The posterior wall is formed throughout its entire length by a continuous sheet called the transversalis fascia.
The transversalis fascia.
Right. Now, medially, toward the midline of the body,
Yeah.
this fascia does receive some structural reinforcement from the conjoint tendon.
Which is the fusion of the internal oblique and transversus abdominis, right?
Exactly. But the vital, inescapable takeaway here is that the transversalis fascia itself is inherently thin,
It's membranous.
very membranous.
Mm.
It is highly vulnerable to pressure.
So when you hear the term direct hernia,
This is the exact anatomical failure point we're discussing.
when the transversalis fascia structurally weakens and bows outward,
The posterior wall has collapsed.
the failure of containment happens right here.
Yes.
So the direct hernia is quite literally a blowout of the back wall.
It's a blowout. The transversalis fascia simply gives up.
That makes complete mechanical sense. We have the tough aponeurotic front door.
And the membranous, vulnerable posterior transversalis fascia.
Right. To complete the 3D tube, we need a roof and a floor.
Okay, so the roof, or the ceiling of our tunnel, is formed by the dynamic, arching fibers of the internal oblique and the transversus abdominis,
They literally sweep over the top of the canal.
like a vaulted architectural ceiling.
Wow. And as for the floor?
That is formed by the inguinal ligament.
Let me clarify the inguinal ligament, because it's not just a standalone rope strung between two bones, right?
No, it's not.
It's actually a continuation of the anterior wall.
Exactly right.
It's the rolled under, thickened inferior edge of that external oblique aponeurosis
It rolled back on itself.
to create a shallow trough.
Yes, which acts as the floor of the canal.
So it's a thickened, folded edge creating a trough.
And medially, as it nears the pubic tubercle, this ligamentous floor is further reinforced by the lacunar ligament.
Okay, let's review our borders. We have the strong anterior external oblique aponeurosis,
The vulnerable posterior transversalis fascia,
the vaulted muscular roof of the internal oblique and transversus abdominis.
and the rolled ligamentous floor of the inguinal ligament.
But structurally, a tunnel requires entry and exit points.
We need to talk about the rings.
Yes, let's start at the very beginning of the pathway, deep inside the body.
The deep ring,
The deep ring.
also referred to as the internal ring. It is essentially a specialized defect.
An opening.
Right, an opening directly within that transversalis fascia we just identified as the posterior wall.
Okay.
It is positioned laterally.
And when we say laterally,
We mean it is lateral to a highly specific, non-negotiable anatomical landmark.
the inferior epigastric vessels.
Yes, this deep ring serves as the starting line.
It is the anatomical point of entry for an indirect hernia to begin its journey into the canal.
Precisely.
So an indirect hernia enters the transversalis fascia at the deep ring, lateral to those vessels.
Right.
It then has to travel the 4 centimeters of the canal and exit somewhere.
And that exit is the superficial ring.
Let's talk about that.
The external or superficial ring is a V-shaped or triangular cleft,
Located in the aponeurosis of the external oblique.
positioned just superior and medial to the pubic tubercle.
So tracing the physical journey
An indirect hernia enters the deep ring laterally
navigates the 4 centimeter tunnel,
and pushes out through the superficial ring medially, right under the skin.
which brings up a really critical question of structural design.
Okay.
Tracing that path, entering laterally, traveling medially, moving from deep to superficial,
Right.
it means the entire canal is oblique.
It sits on a slant.
Yeah, it sits on a slant. If the goal of the abdominal wall is to contain massive internal pressure,
Why would evolution design a slanted 4-centimeter tunnel through the musculature?
exactly, why not just create a short, straight, direct hole for whatever needs to pass through?
It seems like a straight hole would be a smaller weak point,
It really does.
but a straight superimposed hole
Oh,
would be an absolutely catastrophic design for a pressurized vessel.
catastrophic.
Completely. If the deep ring and the superficial ring were stacked directly on top of one another,
Yeah.
any sudden spike in intra-abdominal pressure would instantly blow the contents of the abdomen straight out through the wall.
Oh, wow.
Every time you coughed, you would herniate.
That makes a lot of sense. So the obliquity is intentional.
The obliquity of the canal is not an accident. It is a highly evolved, dynamic, physiological defense mechanism.
Our source material refers to this as the shutter mechanism.
Shutter mechanism.
Break down the biomechanics of that. How does the slant protect the vessel?
Think about the vectors of force during a Valsalva maneuver.
Okay.
When intra-abdominal pressure suddenly skyrockets,
Let's say you are executing a heavy deadlift.
right, the muscular layers of your abdominal wall,
Mm.
specifically the internal oblique and the transversus abdominis, contract violently.
They clamp down.
Yes. And because the canal runs obliquely between these layers,
Yeah.
this fierce muscular contraction acts on the canal dynamically.
It physically pulls the arching muscular roof down toward the ligamentous floor.
And it compresses the anterior wall against the posterior wall?
I see. So it's not a static tube.
Not at all. It's an active valve.
It acts exactly like a physical shutter closing over a window.
Precisely. The obliquity ensures that the very pressure that threatens to force an organ out of the abdomen.
It's simultaneously harnessed to squeeze the canal shut.
Yes. clamping down on the tunnel and sealing the exit.
Increased internal pressure actively tightly closes the door.
It is an elegant, self-sealing biological valve.
That is genuinely incredible engineering. The destructive force is used to power the defensive mechanism.
It's beautiful, really.
But obviously, as surgeons, we know this mechanism fails.
Hernias exist.
Right. If this self-sealing valve is so perfectly designed, why does it break down? What compromises the shutter?
The shutter fails due to the relentless combination of time, physics, and biological degradation.
Wear and tear.
Exactly. As a patient ages, their connective tissues naturally lose collagen density and elasticity.
The aponeurosis thin out.
But it's really the chronic, repetitive mechanical stress that destroys the valve.
Think of a patient with chronic obstructive pulmonary disease.
The smoker's cough.
Yeah, someone who has had a severe barking cough for 20 years.
Or a patient with chronic constipation who strains violently every day.
Or someone whose occupation requires decades of heavy, unsupported manual labor.
They are essentially redlining that pressure system constantly.
Redlining the system, exactly.
And if you add obesity to the clinical picture,
You drastically increase the baseline resting intra-abdominal pressure.
the system is never getting a break.
Never.
Over time, these relentless vectors of force stretch and permanently dilate the rings.
The muscular roof atrophies and loses its contractile force.
The transversalis fascia becomes thinned and distended.
Eventually, the shutter loses its mechanical advantage.
The roof no longer meets the floor during a Valsalva.
The self-sealing valve is incompetent, the pressure finally wins, and
You suffer a catastrophic failure of containment.
it's just mechanical fatigue over decades.
Visualizing it that way makes the pathology so much more intuitive.
It really does. All right, so we've extensively modeled the tunnel itself. We understand the dynamic walls, the entry and exit doors, and the biomechanics of why it's built on a slant.
But biologically, an empty tunnel serves no purpose.
Exactly. This passageway exists to transport cargo.
Let's talk about the specific structures that travel through the inguinal canal.
In the male anatomy, this tunnel is occupied by the spermatic cord.
Right. And what is truly fascinating about the spermatic cord is its composition.
It isn't just a naked bundle of vessels and nerves.
No, it is a highly organized package wrapped in 3 distinct concentric layers of fascial coverings.
This anatomy introduces a concept that is absolutely crucial for surgical comprehension.
Embryological memory built directly into adult anatomy.
Embryological memory. I love this concept.
It's fantastic.
It's like the testicle is packing a terrible suitcase as it leaves the house, just dragging the curtains and the bed sheets out the door with it.
That's a very apt analogy.
Walk us through how that developmental journey dictates the adult surgical anatomy.
Well, during early fetal development, the testicles originate high up in the retroperitoneal abdomen.
Near the inferior poles of the kidneys.
Right. But for proper physiological function and temperature regulation, they must descend down into the scrotum before birth.
And to reach the scrotum, they have to physically punch their way through that 3-layered abdominal sandwich we discussed earlier.
And as the testicle forces its way through each successive layer to carve out the inguinal canal,
Yeah.
it literally drags an enveloping sleeve of that specific tissue layer down with it.
It wraps itself up in successive fascial coats.
Exactly.
So by dissecting the layers of the spermatic cord in an adult,
We are actually reading a historical map of the fetal abdominal wall.
let's identify those coats from the outside in.
Okay,
The outermost covering is the external spermatic fascia.
correct. And based on our embryological model, the external spermatic fascia is acquired as the descending testicle pushes through the outermost layer of the sandwich.
The external oblique aponeurosis.
You got it. Moving one layer deeper, the middle coat is the cremastric fascia.
Which crucially includes the cremaster muscle fiber.
Right. The testicle drags this muscular layer down as it passes through the internal oblique muscle.
And finally, the innermost coat, intimately wrapping the vascular structures.
Is the internal spermatic fascia.
Yes. And it acquires this final, deepest coat at the very beginning of its journey.
As it initially pushes through the transversalis fascia at the deep internal ring.
The embryological descent perfectly dictates the concentric surgical anatomy you must dissect through in the OT.
It's all connected.
Okay, we've unzipped the 3 coats. What is the actual cargo inside the package?
Let's unpack the functional contents of the spermatic cord.
Because this is where a hernia repair transitions from a structural problem.
To a highly delicate, high-stakes neurovascular procedure.
First up, the vas deferens.
The vas deferens is the muscular tube responsible for transporting spermatozoa from the epididymis up into the pelvic cavity.
Physically, when you are palpating the spermatic cord, the vas deferens is unmistakable.
It is a thick-walled, highly muscular, firm structure.
If you roll the contents of the cord between your thumb and index finger,
it feels distinctly like a piece of firm, uncooked spaghetti.
Or a heavy piece of wire.
Right.
The clinical application here is immediate. When you are performing a vasectomy or isolating the cord during a hernia repair,
you aren't just blindly dissecting.
You are actively utilizing tactile feedback to identify that firm whip-like texture to ensure you have isolated the vas.
Absolutely. It is a primary anatomical landmark.
Next, we have the primary arterial supply.
The testicular artery.
Now, remembering our rule of embryological memory, you must understand the origin of this artery.
It does not branch off from the convenient nearby iliac vessels in the pelvis.
No, because the testicle originated up by the kidneys, its dedicated blood supply originates all the way up at the abdominal aorta.
Right at the L2 vertebral level.
Because it's dragging its blood supply down with it during descent.
Yeah.
But that creates a massive surgical vulnerability, doesn't it?
A profound vulnerability. Because the testicular artery has to travel such an immense distance from the L2 aorta.
All the way down through the retroperitoneum, into the deep ring, through the canal, and down to the scrotum.
It is extraordinarily long, thin, and delicate.
It is highly susceptible to inadvertent traction or sharp injury during a dissection.
You have to be so careful.
And obviously, where there is arterial inflow, there must be venous outflow.
That brings us to the pampitiform plexus of veins.
These veins form a dense, twisting network that wraps around the testicular artery.
But our source material highlights a structural asymmetry in how this venous blood actually returns to the systemic circulation.
And it has major clinical consequences.
Very major. The venous drainage pathways are completely asymmetrical.
Break that down for us.
On the right side of the body, the right testicular vein ascends and drains smoothly at a natural acute angle directly into the massive inferior vena cava.
It's a low-resistance pathway.
Exactly. However, on the left side,
things are different.
Very different. The left testicular vein ascends and must drain into the left renal vein.
And it does so at a strict, perpendicular, sharp right angle.
Yes.
Well, let's apply some basic physics to that. Why does a right angle matter in human anatomy?
It's pure fluid dynamics.
Right.
A right angle inherently creates a high-resistance junction to fluid flow.
The left side is already fighting gravity over a long distance.
And now it has to negotiate a sharp, perpendicular turn to enter the renal circulation.
Because of this resistance, the resting hydrostatic pressure within the left pampiniform plexus is chronically higher than on the right.
Which explains exactly why varicocele are predominantly a left-sided issue.
Boom.
There it is.
So for you listening, a varicocele is an abnormal, tortuous dilation of the pampiniform venous plexus.
And the reason you see them overwhelmingly on the left side in clinic isn't random.
No, it is a direct consequence of the higher hydrostatic pressure caused by that 90-degree anatomical intersection at the left renal vein. It's fascinating how a plumbing issue at the kidney manifests as a scrotal swelling.
Anatomy is beautifully interconnected.
What else are we finding in the cord? There's neurological cargo as well.
Yes, specifically the genital branch of the genitofemoral nerve.
This is a critical dual-function nerve.
It provides the motor innervation to that cremaster muscle we discussed earlier,
which allows the testicle to dynamically retract toward the body for temperature regulation and physical protection.
Right. Additionally, it provides essential sensory innervation to the skin of the anterior scrotum.
Okay, and finally, we have the lymphatic drainage.
And here, the source material throws up a massive, flashing red flag for clinical practice.
It calls this the lymphatic trap.
The lymphatic trap.
Let me play devil's advocate here.
Go ahead.
If I have an infection or a pathology in my foot, my popliteal or inguinal nodes swell up.
Right.
If I have a hand infection, my axillary nodes react. Lymphatics generally drain to the nearest regional basin. So if there is a pathology in the testicle, which sits right next to the groin, shouldn't it drain to the superficial inguinal lymph nodes?
That is exactly the logical trap.
It seems intuitive that a scrotal structure would drain to the nearby inguinal nodes.
But you must, once again, defer to the embryological memory.
Right, because the testicle didn't start there.
Exactly. The testicle did not originate in the scrotum. It originated at the L2 level of the posterior abdominal wall.
Therefore, its lymphatic drainage pathways are permanently hardwired to ascend all the way back up the spermatic cord,
Travel through the deep ring
ascend through the retroperitoneum.
and drain into the periaortic lymph nodes situated adjacent to the L2 vertebrae.
Okay, so map out the clinical disaster if a physician doesn't understand that embryology.
It's bad.
How does falling into the lymphatic trap compromise patient care?
It completely derails cancer staging and treatment.
Walk us through a scenario.
Imagine a young male patient presents with a firm, painless testicular mass.
A high suspicion for testicular carcinoma.
Right. If the examining physician simply palpates the groin
Feels completely normal, non-enlarged, superficial inguinal lymph nodes.
and confidently documents no evidence of lymphatic spread,
They have committed a grave error.
they're looking in the wrong basin. Testicular cancer metastasizes deep into the retroperitoneal periaortic nodes.
You cannot feel those on a physical exam.
Never. You absolutely require cross-sectional imaging like a contrast-enhanced CT scan of the abdomen and pelvis.
To properly stage that patient?
Exactly. If you rely on the inguinal nodes, you will understage a potentially lethal malignancy.
That is a chilling example of why rote memorization fails and structural understanding saves lives.
It really is.
Before we move on, we should briefly acknowledge the female equivalent of this anatomy.
Yes,
Obviously, the female anatomy does not feature a descending testicle or a spermatic cord.
correct. However, the inguinal canal still exists in females.
Right.
Instead of the spermatic cord, the canal is traversed by the round ligament of the uterus
This ligament passes through the deep ring, down the canal, and exits the superficial ring,
to eventually anchor and blend into the tissue of the labia majora.
providing structural support to the uterus.
While less bulky than the spermatic cord, the anatomical pathway is identical.
Bringing this all back to the operating theater and the surgical stakes,
Right.
when you are performing an inguinal hernia repair, you are actively dissecting, mobilizing, and manipulating this entire neurovascular bundle.
It is an incredibly delicate environment.
A hernia repair is frequently treated as a routine, bread-and-butter general surgery case.
But it is anything but benign.
If your dissection is careless and you inadvertently divide the vas deferens,
You have instantly caused permanent unilateral infertility in that patient.
wow. If you apply excessive electrocautery or traction and compromise that long, fragile testicular artery,
The testicle will lose its arterial inflow.
the clinical result is ischemic orchitis,
The testicle will atrophy, necrose, and shrink over the following weeks.
which is devastating.
Truly. Understanding the exact nature of this cargo is the barrier between a successful structural repair and a life-altering iatrogenic complication.
Which means being a safe surgeon isn't just about knowing what the structures are.
It's about knowing exactly where you are geographically at every single moment of the operation.
You need a coordinate system.
You do.
And that brings us to the most heavily scrutinized, highly tested, and surgically critical zone in the entire groin.
Hesselbach's triangle.
Hesselbach's triangle.
It is the ultimate geographical landmark in hernia surgery.
It is a defined anatomical space that every surgeon must be able to visualize with absolute clarity before they make an incision.
Before the knife even touches the skin.
For anyone listening who has ever sweated through an anatomy practical trying to recall these exact boundaries,
We've all been there.
our source material provides a classic mnemonic, RALI.
Which stands for rectus abdominis lies inside.
Let's dissect the borders of this triangle using the mnemonic,
The triangle is defined by 3 specific anatomical borders,
starting with the RA in our mnemonic.
which stands for rectus abdominis.
Right.
The lateral edge of the rectus abdominis muscle forms the medial boundary of Hesselbach's triangle.
This is the vertical border closest to the midline of the body.
Correct.
Then we move to the L, which stands for ligament.
Specifically, the inguinal ligament.
We discussed this earlier as the floor of the canal.
Yes. In the context of the triangle, the inguinal ligament forms the inferior boundary, the horizontal base of the triangle.
Okay, and finally the I.
The I stands for the inferior epigastric vessels,
These vessels course obliquely and form the lateral boundary of the triangle.
the border furthest from the midline.
So medial border, rectus abdominis.
Inferior border, inguinal ligament.
Lateral border, inferior epigastric vessels, RALI.
It's a neat piece of real estate.
But why is this specific patch of anatomy elevated to such legendary status in surgery?
It's a good question.
Why do we care so intensely about this particular triangle?
We care obsessively about it because of what constitutes the floor of this defined space.
What's on the floor?
If you are looking anteriorly into Hesselbach's triangle,
Mm-hmm.
the floor, the physical tissue, spanning those three borders,
Yeah.
is composed entirely of transversalis fascia.
Ah, right.
We established at the very beginning of this deep dive that the transversalis fascia is the inherent weak link of the abdominal wall.
It is membranous, it lacks aponeurotic strength, and it is highly vulnerable to pressure.
Exactly.
So by defining Hesselbach's triangle,
We are literally drawing a map around the exact location where direct hernias occur.
that specific patch of tissue.
Yes, this triangle is the precise geographical coordinate of a direct hernia.
When that specific patch of transversalis fascia undergoes mechanical fatigue from decades of Valsalva maneuvers,
It eventually bows out and fails.
the underlying peritoneum and preperitoneal fat do not navigate the oblique tunnel of the inguinal canal,
They simply blow out directly forward.
straight through the weakened floor of Hesselbach's triangle.
That direct trajectory is the very reason it is classified as a direct hernia.
It completely bypasses the shutter mechanism and the deep ring.
It ignores them entirely.
And understanding that geometry leads us directly to what the source text calls the golden rule of the operating theater.
The golden rule.
Put yourself in the shoes of the surgeon. You've made your incision. You've divided the external oblique.
And you are staring at a chaotic, protruding mass of tissue.
The anatomy is distorted by the hernia itself.
It always is.
How do you definitively surgically prove whether the sac you are looking at is a direct or an indirect hernia?
You seek out the inferior epigastric vessels.
They are the absolute definitive dividing line.
They are the North Star of groin surgery.
Once you identify those pulsating vessels, you have your answer.
Exactly. If the neck of the hernia sac is originating medial to those vessels,
Meaning it is erupting through the floor of Hesselbach's triangle.
it is, by definition, a direct hernia.
But if the neck of the hernia sac is originating lateral to those vessels,
It means it is entering the canal through the deep ring, and it is an indirect hernia.
medial to the vessels equals direct, lateral to the vessels equals indirect.
It is that simple.
That isn't just a trivia fact. That is the literal physical structure you are meticulously dissecting to find with your scalpel.
It defines the entire reality of the surgical field.
It really does.
And once you have used that coordinate system to identify the nature of the hernia,
Your next surgical responsibility is to categorize the extent of the structural damage,
which logically brings us to the formal classification systems.
specifically the Nyhus and Gilbert classifications.
Right.
I want to pause here and look at this from the perspective of a tired resident.
Okay.
Why do we bother with these complex alphanumeric classification systems?
It's a fair question.
Is it just academic red tape? Do surgeons just use Nyhus 3B and Gilbert 4 to sound cryptic on morning rounds? Give me the practical utility.
It is the furthest thing from red tape. A robust classification system serves as the definitive blueprint for surgical reconstruction.
The blue.
When a surgeon assigns a Nyhus or Gilbert classification, they are explicitly communicating the precise anatomical defect.
To themselves, their scrub nurse, and their operative team.
It dictates the required complexity of the repair, the specific prosthetic mesh that needs to be opened, and the specific surgical technique that must be employed.
It is the tactical battle plan.
Precisely.
Let's break down the battle plans then, without just reading a list. Let's look at the progression of pathology.
I'm good.
Our source material outlines the Gilbert classification first, which consists of 5 original types that map the escalating severity of the defect.
Plus 2 later additions.
Let's walk through the indirect hernias first.
Gilbert types 1, 2, and 3 map the progressive destruction of an indirect hernia.
Imagine a spectrum of damage to the deep ring.
Right. A Gilbert type 1 is your earliest stage. You have an indirect hernia sac passing through the deep ring, but the ring itself is still small, tight, and snug around the cord.
So the transversalis fascia is perfectly intact.
Exactly.
It's a containment leak, but the wall hasn't crumbled yet.
Then we progress to type 2.
Okay, type 2.
In a Gilbert type 2, the chronic pressure has started to take its toll. The deep ring is now moderately dilated.
The aperture has physically stretched out, allowing a larger sac to pass through.
But crucially, the posterior wall, the transversalis fascia medial to the ring,
Still maintains its structural integrity.
yes,
And then we reach type 3, where the architecture truly begins to collapse.
a Gilbert type 3 is a severe, advanced indirect hernia.
The deep ring has become massively dilated.
It is stretched so far medially That it has encroached upon and compromised the integrity of the posterior wall.
The transversalis fascia is failing,
This advanced category also encompasses massive scrotal hernias
where the enormous sac has descended all the way into the testicle.
and sliding hernias where a retroperitoneal organ like the sigmoid colon or the cecum has been dragged down.
To actually form a portion of the hernia sac wall itself.
Right.
Okay, so types 1, 2, and 3 represent an indirect hernia getting progressively wider and more destructive.
What about the direct hernias?
The direct hernias are classified as types 4 and 5.
Okay, let's look at 4.
A Gilbert type 4 is a catastrophic direct hernia.
The entire floor of Hesselbach's triangle, the whole expanse of the posterior wall,
Has completely blown out.
it's a massive generalized failure of the transversalis fascia.
And a type 5.
A type 5 is also a direct hernia, but instead of the entire wall collapsing, the defect is highly focal.
It's a small, punched-out diverticular defect right through an otherwise sturdy posterior wall.
Yes.
The source notes that later on, 2 surgeons named Rutkow and Robbins realized the map was incomplete and added types 6 and 7.
Ah, right.
Type 6 is a combined hernia where the patient simultaneously has both a direct and an indirect hernia on the same side.
The source calls this a pantaloon hernia.
Which is such an evocative image. We are absolutely going to dive deep into that at the end of the show.
Looking forward to it.
And type 7 is simply a femoral hernia, which exits the abdomen below the inguinal ligament entirely.
Alongside Gilbert, the surgical community heavily relies on the NIUS classification.
The NIHU system is frequently the standard language used for operative planning.
It condenses the pathologies into 4 major types.
Let's map the NIHU system. Walk us through a patient who presents with a NIHUS type 1.
A NIUS type 1 is an indirect hernia where the deep ring remains completely normal in size and configuration.
This is the classic presentation for a pediatric hernia.
Exactly. In a child, the issue isn't decades of mechanical wear and tear.
The issue is purely a congenital sac.
A patent processus vaginalis that simply failed to fuse and close before birth.
So the surrounding fascial tissue is pristine and healthy.
Right. Now, what if the patient is an adult and the ring has started to stretch?
That brings us to NIHUS type 2.
This is an indirect hernia with a significantly dilated deep ring.
But importantly, the posterior wall remains intact.
This correlates closely with the Gilbert type 2.
And type 3 is where the NIHUS system breaks down the complex posterior wall defects.
Exactly. Type 3 is subdivided based on the mechanism of posterior wall failure.
Type 3A is your standard, straightforward, direct hernia pushing through Hesselbach's triangle.
Type 3B is the highly complex indirect hernia.
In a 3B, the deep ring is so massively dilated that it has eroded medially and completely destroyed the transversalis fascia of the posterior wall.
And type 3C classifies the femoral hernias.
Finally, NIHUS type 4.
NIUS type 4 is an entirely different beast.
It is reserved exclusively for recurrent hernias.
These are hernias that have already undergone surgical repair, but the repair has failed and the hernia has returned.
Type 4 is further subdivided into A, B, C, and D based on whether the recurrence is direct, indirect, femoral, or mixed.
Recurrent hernias are a surgical nightmare.
Because the normal anatomical planes we've discussed have been obliterated by dense scar tissue from the primary operation.
There's a mess in there.
Let's bring this all together to show exactly why a surgeon cares about these categories.
Okay.
Let's compare 2 hypothetical patients to demonstrate how the classification literally dictates the surgery.
Sounds good.
Patient A is a 5-year-old boy. You open him up and classify him as a NIHUS type 1.
What is the precise surgical action?
For a pediatric NIHUS type 1, the operative approach is minimalist and elegant.
Because the abdominal wall musculature and the transversalis fascia are entirely healthy and structurally sound.
Right. There's no need to rebuild the canal.
The surgeon simply dissects out the congenital hernia sac,
Traces it high up to the deep ring.
ties it off securely with a suture, a technique known as high ligation, and amputates the sac.
You address the abnormal sac, but you leave the pristine native architecture entirely alone.
Minimal intervention because the vessel is sound.
Now look at patient B, a 65-year-old man who has done heavy labor his whole life.
Okay.
You open the canal and classify him as a NIHUS 3B. He has a massive indirect hernia that has stretched the deep ring so far medial that the entire posterior wall is obliterated.
Right.
If you just tie off the sac like you did in the child, what happens?
If you perform a simple high ligation on a NIHUS 3B, the hernia will recur almost immediately.
The structural containment vessel is shattered.
Tying off the sac does nothing to fix the gaping hole in the abdominal wall.
For this patient, the classification mandates a formal posterior wall reconstruction.
The surgeon must physically rebuild a new transversalis fascia layer.
Historically, this was done by meticulously suturing the native tissues together under tension.
Such as in the shoulder repair.
But today,
Today, it is almost universally managed by reinforcing the entire posterior wall and deep ring with a synthetic prosthetic mesh.
known as a Liechtenstein tension-free repair.
Right. The NIAS classification definitively told the surgeon to transition from a simple sac excision to a complex structural reinforcement.
The label is the battle plan. It's brilliant.
It really is.
Okay, we have thoroughly mapped the static anatomy, we understand the dynamic physics of the canal, and we know how to classify the damage once we are inside.
Let's bring this into the clinic.
Direct versus indirect. A patient is sitting on your exam table complaining of a groin bulge. Before you even touch them, how do you begin to differentiate the two pathologies?
You begin with the epidemiological profile and the physiological origin of the defect.
Let's look at the indirect hernia first.
Indirect hernias are overwhelmingly the most common presentation overall.
And they are particularly prevalent in younger demographics, specifically young males.
Right.
And the reason for that skew toward youth goes right back to the embryology, doesn't it?
It does. The anatomical substrate for an indirect hernia is very often congenital.
We discussed how the testicle drags a layer of peritoneum with it during descent.
Normally, that peritoneal sleeve seals itself off and obliterates.
But if it fails to fuse,
It leaves a preformed open pathway connecting the abdomen to the scrotum.
the patent process is vaginalis.
Exactly. An indirect hernia sac simply utilizes this pre-existing highway
It enters the deep ring, travels the entire length of the oblique canal.
and can easily exit the superficial ring to descend all the way into the base of the scrotum.
Simply because it is following the precise historical path of the testicle.
It's taking the path of least resistance on a pre-laid track.
Contrast that patient profile with someone presenting with a direct hernia.
Direct hernias present almost exclusively in older male populations.
This is rarely a congenital defect.
No, it is a progressive, acquired disease of structural wear and tear.
Decades of heavy lifting, chronic coughing, or simply the inevitable age-related degradation of connective tissue collagen.
Eventually causes the transversalis fascia within Hesselbach's triangle to fail.
The tissue does not navigate the oblique tunnel.
It simply bulges straight forward through the weakened wall.
Because of this direct perpendicular trajectory, a direct hernia rarely has the anatomical alignment to descend deeply into the scrotum.
Correct.
And geometrically, because a direct hernia is essentially a generalized bowing out of an entire fascial wall.
It tends to have a very wide, broad base, correct?
Precisely. A direct hernia features a wide neck that corresponds exactly to the broad area of fascial weakness in the posterior wall.
So the profile gives you an initial suspicion.
But you have to examine them. Our source material highlights a classic clinical maneuver called the deep ring occlusion test. Walk me through the mechanics of executing this test on a patient.
To perform the deep ring occlusion test, you first have the patient lie supine, which removes the force of gravity.
And you physically reduce the hernia.
Right. You gently manipulate the protruding tissue back through the defect into the abdominal cavity.
Once the canal is empty, you place your thumb or two fingers firmly over the precise anatomical location of the deep ring.
Geographically, that is roughly at the midpoint of the inguinal ligament, just lateral to the pulsation of the inferior epigastric vessels.
You press down firmly against the posterior wall to physically barricade the deep ring.
While holding that pressure, you ask the patient to stand up and cough forcefully.
You are intentionally generating a massive Valsalva pressure wave while blocking the front door. I see the logic.
It is a simple binary test.
If the patient coughs and the swelling does not reappear,
You've confirmed an indirect hernia.
because by physically occluding the deep ring, you have barricaded the only entrance to the tunnel.
The bowel wants to herniate, but your thumb is blocking the pathway.
However, if the patient coughs and the swelling instantly bulges forward right medial to your occluding fingers,
You have confirmed a direct hernia.
because the direct hernia completely ignores your blockade at the deep ring.
It utilizes an entirely different exit strategy. It simply blasts straight through the weakened posterior wall of Hesselbach's triangle.
Conceptually, it's an elegant test.
It is.
But let's be realistic about clinical practice. The source text is very careful to caveat these physical exams.
And for good reason. Clinical tests like the deep ring occlusion test or Siemens three-finger test sound foolproof in a textbook.
But they are notoriously imperfect in reality.
If your patient has a BMI of 40 and a thick layer of subcutaneous adipose tissue,
Precisely isolating the deep ring with your thumb is nearly impossible.
if the hernia is incredibly massive and has distorted the local anatomy, differentiating the exact point of origin by feel is a guessing game.
Which routes us right back to our golden rule.
The physical exam gives you a working theory.
But absolute, definitive diagnosis requires direct visualization of the inferior epigastric vessels in the operating theater.
Exactly.
Let's pivot slightly and address the most terrifying aspect of hernia pathology, the mechanics of strangulation.
Right.
Why is it that some patients walk around with a massive groin bulge for 30 years with nothing more than mild discomfort?
While another patient develops a hernia and is dead within 48 hours without surgical intervention.
The difference between a benign nuisance and a fatal surgical emergency comes down to fluid dynamics and the physical dimensions of the structural bottleneck.
Let's evaluate the direct hernia first.
We noted earlier that direct hernias have a wide, broad neck because they emerge through a generalized blowout of the transversalis fascia.
Because that entry point is so wide, any omentum or loops of bowel that slide into the hernia sac can usually slide right back out into the abdomen with ease.
The vascular supply to that bowel is rarely pinched or compromised.
Therefore, direct hernias carry a very low risk of strangulation.
But the anatomy of an indirect hernia creates a perfect storm for a vascular catastrophe.
Exactly. An indirect hernia does not have a wide neck.
No.
It is forced to squeeze its way through the deep ring.
And the deep ring is a defined, discrete fibromuscular aperture within the transversalis fascia.
It acts as a rigid, unyielding collar.
When a segment of intestine forces its way through that tight collar and into the sac, it is highly vulnerable.
If the bowel fills with gas or fluid and swells even slightly,
Or if the abdominal musculature spasms around the ring.
the bowel becomes trapped. It becomes irreducible.
And once it's trapped, the vascular clock starts ticking.
It initiates a vicious cycle. The tight collar first compresses the low-pressure venous system,
Venous blood cannot drain out of the trapped bowel.
so the tissue becomes rapidly engorged and edematous. It swells massively.
As the tissue swells within that confined space, the pressure inside the sac eventually exceeds arterial pressure.
The high-pressure arterial inflow is completely choked off.
Oxygen delivery ceases.
The bowel tissue rapidly becomes ischemic, infarcts, and begins to necrose and die.
That is strangulation.
It is a lethal cascade.
Which brings us full circle, perfectly solving the midnight mystery we opened the show with.
Let's review that exact scenario.
You are staring at a 45-year-old manual laborer. He has had a reducible groin swelling for 2 years.
Tonight, the swelling became firm, intensely painful, and irreducible.
He is vomiting profusely, and his abdomen is severely distended.
Using the structural logic we've built over the last hour, walk me through the deduction.
We can confidently diagnose the precise pathology without even making an incision.
The patient has a known hernia that is suddenly irreducible and deeply painful, indicating the tissue is trapped at a structural bottleneck.
The vomiting and massive abdominal distension are the hallmark clinical signs of a mechanical bowel obstruction.
A segment of his gastrointestinal tract is trapped inside that hernia sac, completely blocking the forward flow of intestinal contents.
And because we know the anatomical mechanics of the bottlenecks,
Because we know that direct hernias possess wide necks and only rarely trap or strangulate bowel.
we can deduce with near absolute clinical certainty that this patient is suffering from an indirect hernia.
A loop of his bowel has navigated through the deep ring, expanded, and become fatally trapped by the tight fibromuscular collar.
The venous outflow is already compromised, the bowel is obstructed, and arterial strangulation is either imminent or already underway.
So when your senior surgeon looks at you and demands to know the next step,
The only correct answer is an immediate emergency laparotomy or groin exploration.
the containment vessel has failed, the structural bottleneck has trapped an organ, and the patient's life is in immediate jeopardy.
We must rush him to the theater, incise the external oblique.
Carefully divide the constricting ring to release the pressure.
Meticulously assess the color and viability of the bowel to determine if a resection is required.
And finally, reconstruct the structural integrity of the inguinal canal to ensure it never happens again.
It is incredibly satisfying how, by abandoning rote memorization and simply deconstructing the functional anatomy from first principles,
A terrifying, chaotic midnight trauma scenario simply reduces into a logical, sequential series of anatomical deductions.
It really does. Let's rapidly consolidate this immense amount of information.
Yep.
Our source material elegantly distills this entire deep dive into 5 core, non-negotiable surgical truths. Let's run through them. Number 1.
Truth number 1. The inguinal canal is not an accidental anatomical defect.
Right.
It is an intentional oblique tunnel, and that specific obliquity acts as a vital, dynamic, physiological shutter mechanism to defend against spikes in intra-abdominal pressure.
Number 2.
Truth number 2.
Hmm.
The posterior wall of that canal is formed entirely by the transversalis fascia.
Right.
It represents the inherent structural weak point of the groin, and its mechanical failure is the definitive, defining characteristic of a direct inguinal hernia.
Number 3. The absolute rule of the OT.
Truth number 3. The inferior epigastric vessels serve as your ultimate, indisputable operating theater landmark. Origin medial to the vessels definitively equals a direct hernia. Origin lateral to the vessels definitively equals an indirect hernia.
Number 4.
Truth number 4. Hernia classification systems, like Nyhus and Gilbert, are not trivial academic exercises.
They're precise structural blueprints that dictate exactly how extensive and complex your surgical reconstruction must be.
And finally, truth number 5, the physiological distinction that separates a chronic nuisance from a lethal emergency.
Truth number 5. Direct hernias feature wide fascial necks and therefore rarely strangulate.
Indirect hernias must navigate the tight, fibrous bottleneck of the deep ring, making them highly susceptible to trapping bowel, causing obstruction, and progressing to fatal strangulation.
If you internalize those 5 points, you possess a profoundly deep functional mastery of this topic.
Absolutely.
But we can't let you go without delivering on the provocative final thought we promised earlier.
A true structural cliffhanger for you to analyze before you step into your next surgery or study session.
We spent this entire session establishing very clear, distinct rules.
We know that direct hernias result from a posterior wall failure, punching straight through Hesselbach's triangle.
We know indirect hernias utilize the deep ring to navigate the oblique tunnel.
They represent 2 entirely different mechanisms of failure, taking 2 entirely different pathways.
But human biology is rarely perfectly clean, and mechanical failure doesn't always respect our categories.
What happens to the structural integrity of the groin when both of these mechanisms fail simultaneously? The exact same patient on the exact same side.
The Gilbert type 6, the infamous pantaloon hernia.
Imagine the chaotic anatomy of that patient.
You have a patient who perhaps has a congenital dilated patent processus vaginalis, allowing a massive indirect sac to form at the deep ring.
Simultaneously, decades of chronic coughing have completely obliterated the transversalis fascia in Hesselbach's triangle, creating a massive direct sac.
When you make your incision and open the canal, you locate the inferior epigastric vessels, and you are confronted with an absolute structural disaster.
You see one distinct hernia sac protruding medially to the vessels.
And a second, entirely separate hernia sac protruding laterally to the vessels.
They literally drape over either side of the inferior epigastric vessels like a pair of pants draped over clothesline.
Hence the historical name, pantaloon.
The containment vessel hasn't just sprung a leak. The door is blown off its hinges, and the wall next to it has completely caved in.
It's a total architectural collapse. So the question we want to leave you pondering is this.
As a surgeon, how on earth do you approach repairing a pantaloon hernia?
How do you reestablish a high-pressure containment vessel when both the shutter mechanism and the posterior floor have completely disintegrated simultaneously?
What specific tissues do you even sew together, and what does that complex 3D reconstruction physically look like?
It is a scenario that requires an absolutely profound mastery of tissue tension, the biomechanics of prosthetic mesh materials, and dynamic spatial reconstruction.
It represents the ultimate test of the surgical thinking we have labored to build today.
And considering the mechanics of that dual repair perfectly sets the stage for your future explorations.
Because if you truly want to understand how to fix these complex defects,
if you want to understand why the Schuldis multi-layered repair was revolutionary, or why the Liechtenstein tension-free mesh repair became the gold standard, or how the minimally invasive laparoscopic TEPI and TEPP procedures managed to fix the wall from the inside out,
you cannot just memorize the steps.
you have to start with the foundational biomechanics we laid down today. True structural understanding will beat rote memorization every single time you step up to the operating table.
It is the only reliable way to develop into a truly safe, highly effective clinician.
When you deeply understand the why of the structural failure, the how of the surgical repair simply becomes obvious.
I couldn't agree more.
Thank you for joining us on this incredibly extensive, granular journey through the structural anatomy and physiological logic of the inguinal canal.
We genuinely hope this deep dive into the source material has fundamentally shifted your perspective on how to view the complex architecture of the human body.
Keep pushing past the flashcards and keep building that surgical thinking.